Hello, thank you all for the platform today. I'm coming from a little bit further away. Unfortunately, I have actually written West Midlands academic science health work. I only thought that I included Oxford, so I wanted to say sorry to academic sciences in West Midlands. I need to send a little disclaimer to you to say that I've been endorsed by Abbott Diagnostics and Biopharmaceuticals. Abbott did sponsor the whole project of the piloting, the case that I will be presenting. So I hold a great thanks to Abbott Diagnostics in enabling us and sending a punt to us to let us do this job. There's a big buzzword in hospitals, and even now in summer, is the patient flow. Everybody talks about patient flow as if they're a little torrent of something. To me, it seems that patient flow is a fixed entity. It doesn't change, it doesn't go up, it doesn't go down. There are no floodgates. Nobody's tackling the fact that actually that patient flow has to be a little bit more dynamic on the shop floor. However, we're all here talking about patient flow, talking about new novel methods of dealing with it. And we are the pioneers of this. And one thing that I really struggle with is actually getting us into the real world and making change happen. David Oliver, professor from Royal Berkshire, on behalf of RCP, appealed to all the consultants and all the senior doctors in the country in the latest RCM journal to say, please guys, you're actually capable of affecting the patient flow. Don't induce yourself into passive helplessness. He offered some very, very useful targets. And the first target is actually prevent hospital admissions. Channel that supply chain, disrupt that supply chain at the outset. And Professor Lassison just clearly demonstrated how it can be effectively done in Oxford, in the community. He also mentioned use of rapid diagnostics in the process of enabling that to happen, utilizing multidisciplinary team. And we don't talk about multidisciplinary team of a consultant sitting and a bunch of cronies around him acquiescing to every single word he or she says. It's about utilizing each other's strengths to actually deliver the outcome. And the only thing I'll be talking about here are the outcomes and how we reach them. All of these agendas are extremely disruptive to the status quo. You do not make friends by disrupting the status quo. And the status quo of the NHS is extremely powerful at preserving itself. I mention Kaiser Permanente because this is the headline statement, that unplanned hospital admissions are seen as a system failure. Kaiser Permanente is an integrated healthcare system. And as much as we like to slack it for it being private, for it taking 5 million people who are well off, all of these people do get sick, all of these people do get old. But they do not make mistakes as we do in creating global inefficiency of the healthcare. They are very responsive. They do cost a lot of money because they haven't figured out how to be cheaper still. There is a certainty through modeling. What strikes me about this statement is the fact that unplanned admissions are not chaotic. They can be modeled, they can be foreseen, and they can be acted upon and mitigated. So therefore, unplanned admissions are not a chaotic admissions. And this is what we used as a kind of our benchmark to develop the service. Now, we do love our NHS, and now, unfortunately, at the moment, poor NHS looks like a sinking ship. And it's a great thing. Everybody loves to go on a cruise liner, but when it's kind of a little bit tilted, you kind of try to ask yourself questions whether it is right for me. 46% of the population, or 62% of the population now is saying they're not comfortable with what's going on. We can't rely on these little kind of beacons of excellence of these little ships who are running around and trying to save the issues. We really need to straighten the ship up, make it effective. Let it not grind to the shore. This slide just illustrates that ambulatory services are good. You know, they are force for good. We know that now we've been drilled into this kind of mantra, and I completely concur with this. This slide also shows that we are wasting £1.5 billion a year, and I think this is a gross understatement. This understatement is as gross as the understatement of the benefit of ambulatory services that is demonstrated here of 683 million. I think probably we're talking order of magnitude higher if we implement it properly and we allow it to flourish. At James Paget Hospital, which is a 450-bedded district general hospital in the furthest east of our country, we tried 3 times to open up ambulatory services. But the conflict was the bed state. We were implementing them in the current state. And always the beds would take the priority. When I talk about beds, think about a capacity question I'll ask you in 10 minutes. It was very poorly implemented. Then one day, I had a flourish of people in my office. There was a point of care coordinator, there was Abbott representative, and they're saying, can you use point of care technologies? What would you use them for? Is this good for you? And I said, absolutely yes. And I'll tell you why, because we need to look at the reasons why it is good for me. And they said, let's just go and start something afresh. Let's just be effective. Let's just be safe. And let's just offer the patients personalized care at the right time with the right person at the right place, as Professor Darzi said. Let's make it process-driven. Let's not make it personality-driven. Because ultimately, what we're talking is the outcome. An outcome is a patient with an improved healthcare status leaving the hospital, i.e. health discharge. That's the outcome. The outcome is not my presence there and me making decision and everything revolving around me. So the process is the king and the patient is the benefactor. Let's use the technology enablers, whatever they may be, whether this is IT, ultrasound, as Professor Lasson was talking, point of care enablers, or people themselves. We always forget that 80% of the NHS budget are people, is used on people. I had grandiose ideas. I don't think that my ambulatory service that we designed in James Paget is in the right place, but it was the only place available to us. I wanted it to be a linchpin for the community integration. We are so disrupted by the fact that what community does not translate into the hospital or vice versa. We felt that we will be able to reach out with our flexibility. We felt that we will be able to enhance the MDT that is already in the community so that actually they have got a point of contact which is flexible and approachable and there at all times. Abbott Point of Care Diagnostics, they've identified that we were talking the right language about introducing the right process in which both the diagnostics side of things as well as us, including the patients, can benefit. And they took the pun and they funded the pilot project. The hospital was not keen to engage. It's very difficult to get a hard cash from the NHS to fund something new. And you're testament to the hard work of trying to engage those people. I had to define value. Why do I want ambulatory services? And I, as an acute medicine consultant, I have 2 problems every time I do a ward round. First one is, oh my goodness, if you only came 2 days or 3 days earlier to me, I could have fixed you, hopefully, and you wouldn't have ended up in hospital with a length of stay of 7 to 10 days with a potential critical care illness. So I wanted people to present to me earlier. But at the time, I had no resilience of the system to allow me to advertise myself to the community to say, bring these people in, because I would have drowned. Second problem is, at 6 o'clock in the evening, you would find a person and you would say, goodness me, if I could only see you 3 or 4 hours earlier, I could have discharged you home. So I have a hospital length of stay, which is a disaster. We looked at the processes. We looked at what we were doing now, what is the ideal process, and we looked how to redesign the processes so that they fit the ideal activity, so that we are super efficient, super safe, super cheap, and super satisfactory for our patient. We had to target, destroy, disrupt. I'm using very, very harsh words of this kind of terrible triple D. And this is delays, defects, and deviations. And they're always with us. They follow us throughout the day. When you learn a little bit about lean, you become very frustrated with the world because it's inefficient. The whole thing was underlined with the rigor of failure mode and effect analysis. We had the ideal state. Everything we brought in was initially destroyed and rebuilt to allow to see how it fits. There was no one voice. There was multiple voices of horizontal hierarchy, building up from bottom up any ideas. And they would be destroyed by everybody. And if they were indestructible, they would go in. It was a very quick way of reintroducing new ideas and new concepts. Let's look at the delays that we identified. Can you see? All right. Oh dear. So that's a bit of a disaster, unfortunately. Good. So we had the delays in the referral. Our supply chain were GPs and our supply chain was A&E. They didn't have a clue that we existed. They didn't have a clue what we were doing. It was very difficult to change their minds. A&E categorically refused to send the patients to us because they knew that we would historically expect everything to be done for the, they would expect that we would expect of them everything to be done for the patient before we see them, because that's kind of a gatekeeping. We disrupted it completely and we said everybody has got an open access, to the point that we were actually pulling patients from A&E, introducing ourselves to the GP so they can actually push people in, and allowing process to enable this to happen. We had delays with diagnostics. It was absolutely terrible. It takes an hour and a half to get a blood test. Do we really need blood tests? Well, for some people we do, and certainly for people presenting with acute medicine conditions. So we started using point-of-care testing. And we'll talk about point-of-care testing in a minute. I've lost one slide to show you which ones we use. So like Professor Lasserson, we use the ISTAT for user needs. We've also got the benchtop analyzers that we use for full blood count. I5 full blood count, extremely important in taking care of acute medicine patients. We've introduced VT service, so therefore we've got the D-dimers in it. It can do procalcitonin as well, so we've worked with intensive care to see the utility of procalcitonin. I can talk to Dan about it later on. We have ability to do troponins, but we don't do them because we are working on other models of channeling those patients. Radiology was a bad thing for us. X-ray takes an hour and a half. How much benefit do you get from an X-ray? So everybody gets one shot at an X-ray in our department. Second shot of the X-ray you need to discuss with everybody because that results in a delay in patient processing. Getting CTPAs or CT heads was impossible to do. It was a revolution that we managed to achieve an agreement that we will get a CTPA done. Oh, this is a chest CT for those who are not medical here. In 48 hours. Guess how much time lapses now from the request to the CT during the working hours? 45 minutes. And you know why? Their main delay is the patient transport to the CT. They don't have porters. So therefore these people just walk to the CT and come back. And they have ample of time to increase their capacity. And we have increased their efficiency by 85% just by using 4 CTs a day that we require for headaches or for the chest. We need to know what are the stumbling blocks of our allied specialties around us. We use ultrasound avidly, starting from the chest for diffusions, for the pneumothoraces, for the evaluation of the heart failure, looking at ascites, looking at hydronephrosis, looking at the gallbladder, targeting the DVTs. But most importantly, offering patients the choice to be at home with the IV antibiotics. Some of them will have them for weeks, and offering them central line service or the midline service that we do. And even our nurses are doing it now. So there's an ample utility of ultrasound that Professor Lasserson has touched on. And the senior decision maker is the most important linchpin in this whole environment. Extremely disruptive proposition to have a consultant at all times available. Surely we turn up, we batch our patients, see them in the morning, see them in the evening, and in the midway through it, we go to play tennis or golf. Not true really, we go on to meetings and try to do our audits and stuff. But to have a senior decision maker there at all times was a revolution. And if I tell you that when I work in ambulatory unit, I get 2 or 3 phone calls per day, only to manage the whole cohort of people, you would be very surprised. Because people become autonomous, people follow the process, people follow the understanding, and they only call when they have a delay, whether this is a cognitive or whether this is structural delay. This is Tamara here. We are using a point-of-care device at the patient's bedside. She is a CSA, below band 4. If I tell you that she manages about 70% of discharges home, you would be surprised again, wouldn't you? Imagine a 42-year-old lady. She's telling me now about a 42-year-old lady who's got premature menopause, who is hypertensive on some antihypertensive medication, and she's coming with a chest pain. ECG done by the paramedics was negative, so therefore they could come to us, okay? What would you do next? You would go on a barrage of tests, wouldn't you? Troponins, D-dimers, X-rays, who knows what. However, Tamara found that she's got that medical history, that her dog died and the husband is offshore. And she's now alone, extremely anxious, and that she hyperventilated when Tamara was talking to her. Tamara said, I took full blood count and Chem8 cartridge for Usenis for the ISTAT. I'm going to keep the D-dimer and troponin aside. I don't think she needs a chest X-ray, Josip. I think she just needs you to reassure her and potentially just put your ultrasound probe to exclude the pneumothorax, which is exactly what I did. The patient was gone home in 15 minutes. Tamara decides when I see patients. Tamara pushes us to meet the target of patient turnaround. Band 3. She's now doing a nursing degree. We empowered her. We emphasized her importance. This is the first time in her life that she felt valuable, and she will thrive. And in the next 5 to 6 years, I expect to see her as a head of department. Let's get rid of the defect. Outcome, mortality, morbidity. Our mortality we looked at the patients of 0 to 3 day admissions. Their mortality was 2.6%. With the introduction of ambulatory services, that dropped down to 0.6%. 75% reduction in mortality. Now we are targeting unexpected mortality. Those are the people who wait in the waiting room for Godot. They get seen in 7 minutes. So this is the unexpected mortality, but we're also targeting that expected mortality of people. These are the people who come those 2 days earlier. GPs know that they can refer before they are off their feet. And these are the people who gain that immediate benefit. We are not drumming up business. We are just getting people earlier, target them, and keep them back in the community. Technology never fails. Technology works on 6 sigma. 1 in 50 in a million chance of technological failure. So we completely disregard it. And look what we've got. We've got the ultrasound machine there, which is always there. I'll tell you about how many people we see per week. But let's just look at deviations. Let's keep to the message. 85% of presentations which are unplanned are predictable. We know what they are. They are one of the 5. We can predict with 85% certainty when these people will come. So we can work around workforce that will deliver that outcome. Our model failure is 1 in 200. I will have 0.5% defect, whether this person is going to die or whether this person is going to suffer an unexplained problem. And the senior decision maker is regarded as a gatekeeper of that deviation avoidance. But I think that they're not qualified to do that. I believe that the chief of nursing should be doing that because they're much more rigorous about it. And when empowered to use their autonomy, they're very good at it. So this is our results from 2016. I think very few of us can see it. And you can see on the top left is the emergency referrals by source per month. So basically you can see that actually we still get GPs. So GPs are blue, and the emergencies are blue, GPs are red. So they kind of predominate. But we are very proud to say that we've expanded the kind of referral sources. So we get community nurse practitioners, paramedics referring directly to us, and they're always encouraged to do that. You will see on the top right slide that the red ones are the new arrivals, the de novo patients. The rest of them are kind of returns. And Professor Lasseson was talking about this kind of continuing care, this continuing enablement of patient progression. And so we will have people coming back for whether this is for bloods, for another evaluation. Now we are being even riskier. We tell them, please call us. I expect this tangent of your progression, and if this tangent is not met, please call us, we want you back. Okay? And it works absolutely perfectly well. Our length of stay is 115 minutes in average. 6 hours is the expected in the rest of the country. We are talking 115 minutes turnaround time. And that turnaround time is extremely important because I can have less staff, I can have less space to deliver the same outcome. Why batch? Why create a warehouse out of the hospital? And you can see the patient length of stay per day. It kind of goes down significantly on Saturday and Sunday simply because this is primarily elective stuff. Community services don't exist effectively, so there is no kind of input stream from them. So reality of 2016 is we've got paramedics and community nursing referring to us as a kind of, they're building up their portfolio. And one stream I missed here. Do you know which stream is that? Patients themselves. We keep the possessions of those patients for as long as their episode lasts. So they have their numbers. So increasing number of patients have got increasing number they've got our numbers. So we do get patients calling us and saying, I'm now in a different state, can you help us? So we are becoming a linchpin, becoming a bit of a victim of our own success. We are limiting the exclusion criteria. Whenever you set up a service, do not ever include inclusion criteria, because inclusion criteria are vast, very few people will look at them, and they will try to avoid this. When you're going to the kind of high street fast food chain, they don't give you the inclusion criteria. The only inclusion criteria is you have to have an idea that you are hungry, and you have to have money. That's the only thing. We only say, and I love using this stuff, if I can, in an event of a fire alarm, turn you around 180 degrees and send you off home, you qualify to come to my ambulatory service. Okay? We became a little bit brave. We started introducing chest pain pathway, and that is working very well, but it requires quite a lot of pull from the A&E. So we are struggling with kind of between the elective side of things and emergency side of things to target this group. And we've also had to introduce our VTE service because the VTE service was so inefficient that within 5 days we turned it around, introducing it into a model. So from £90,000 wasting per year service to a £500,000 profit service with a turnaround time of 1 day in 24 hours is kind of a benchmark of what you can do with a good process. As I said, we are a slight victim of our success because the funding for us is kind of stalled, but the expectations remain very high. Ambu is used now as a trademark to kind of introduce the process into other areas. And as talking to Professor Lasson, we are working very hard to introduce community hubs, community modules as modeled on Professor's earlier examples. And just to summarize, we need to understand the purpose. We need to know what we want to achieve, and we need to strive to design the process around it which is effective. Remove all your preconceptions before that. You need to deliver that ideal state, but the hardest thing is to sustain this under the barrage of continuous pressures. And this is what I'm learning now. This is my next step of learning. Thank you.